next, I wanted to invite our Vice President of this organization, Dr. Kilpatrick, to introduce our keynote speaker, Dr. DeFronzo.
We have the great Dr. DeFronzo here with us today. We are so fortunate that he came to a small town in Arkansas to talk to us about the management of type 2 diabetes, which I would argue is the most important thing we could talk about. So a little bit about Dr. DeFronzo, although he doesn't really need an introduction. So you know who he is. He is a professor of medicine and the chief of the diabetes division at the University of Texas Health Science Center and the deputy director of the Texas Diabetes Institute in San Antonio. He's been across the world recently, so thank you again for coming. His major research interests focus on the pathogenesis and treatment of type 2 diabetes and the central role of insulin resistance in the metabolic cardiovascular clusters that we love to know as insulin resistance syndrome. He's had many, many awards through his long career, including the Banting Award from the ADA, the Claude Bernard Award from the EASD, both in 2008, and just this year he received the Prince Mahidol Award, which recognizes a person worldwide in medicine and science who has made major discoveries leading to advances in global health. Oh, it gives me goosebumps. So with more than 800 articles published in peer-reviewed journals, he's a distinguished clinician, teacher, and investigator, and has been invited to speak at many national and international conferences, and he came to a small town in Arkansas to talk to us today about type 2 diabetes. Dr. Here's your clicker.
Perfect. Yeah. Okay, so it's a pleasure to be here. I have to say, it is my first time in Little Rock. Someone asked me, what did I think about it? And I said, well, the airport was small, and the embassy suites was nice. So I haven't had an enormous experience, but maybe if we come back again, I can see a little bit more. So I am going to talk about type 2 diabetes, and for those of you who are familiar with my background, I'm a strong believer that if you understand what causes a disease, you'll be better prepared to treat it. Unfortunately, what we've done in the past in diabetes is to treat people with medications that really don't correct the underlying pathophysiological disturbances, and I'm going to take you through that background briefly. But today, and we were talking about this the other day, when I brought metformin in 1995 to the United States, we thought that was like, God had come and shed light on us. Because we had insulin and sulfonylureas, and that was pretty barbaric because those were the only two medications that you had. So we thought metformin, wow, what a breakthrough. But today we have, a plethora of different classes of drugs and drugs within classes that we really can make a big difference in the control of our diabetic patients. And what I'm going to do is to take you through the DeFronzo approach. I'll shock you right up front. I really don't believe in the ADA guidelines. And so what you're going to see is going to be very different from what you may have been taught. In my life, I actually have made one mistake, and then 2 weeks later I found out I was wrong. So if you want to bet against what I'm going to tell you, you'll probably end up being on the wrong side. Now, if I push a button,
Try the
right
button.
Right button?
There it is.
Okay. So I'd like to start with this slide just to drive home that diabetes is a big problem. So every day of our existence, there are 4,000 new cases of diabetes. When you think about that, that's pretty staggering. This is not per week, this is per day. There are 800 people who die every day from diabetes. There are 200 or so people who have an amputation every day. If you live in South Texas, they're probably higher than that. There are 120 people who end up on dialysis every day, and there are 50 people who go blind every day. So when you think about it in this perspective, you understand it's a huge clinical problem. And every single person in this audience, I'm sure, today is going to have one or two, if you're going to your practice, you're going to have one or two or more diabetic patients in your practice, and you're going to be facing these issues. So how well are we doing in the United States? So this is a plot of the in the US of the A1C going from year 2000 up to the present time. And you can, if you look at the white line, you can see that is people who have an A1C that's less than or above 7. And you can see that about half of the people in the United States are above that line, have an A1C above 7, which is the recommended treatment goal, which says if half of the people are above 7, we're not doing such a good job. Now the yellow curve is the number of people with an A1C above 8, and you can see that about 25 to 30% of the people have an A1C that is above 8. So we have really a large number of people in the US, and we have 37 million type 2 diabetics, who really are not being adequately controlled. Now there are a number of reasons why we fail to get these people controlled. Our approach, and I'm going to show you a slide on this in a second, our approach is what I call the treat to fail approach. We put someone on a drug. The usual first drug is metformin, and then we see the patient back a year, 2 years, whatever, and then all of a sudden the A1C that was controlled now has gone up to about 7.5. We add a second drug. And then the second drug is usually a sulfonylurea, and then that works for a while, and then they fail. Then we add a third drug, usually it's an DPP-4 inhibitor, and then finally the patient ends up on insulin. So we're always sort of back-loading our treatment. We wait till the A1C is out of control. We're never sort of treating up front. Physician inertia, and this has been shown in every study that's been looked at. People will get the A1C, they'll see it's inadequate. It can be 7.5, 8, 9, and it takes oftentimes years before they actually increase the dose of the medicines they're on, or they add the next dose. Patient non-compliance. So if the patient is not going to cooperate with you, you will lose 100% of the time. And there are no physicians that I'm aware of that can spend enough time with the patient that actually communicate what needs to be communicated. So diabetes educators, dietitians, pharmacists are critical. Without them, my life would be destroyed. They're the ones who really are doing the heavy work in my practice. The cost of medications is oftentimes prohibitive for patients. And the newer medicines, I think everybody knows that all the Hollywood stars now, they all have slimmed down while they're all on Mounjaro. Okay? But Mounjaro is $1,200 a month. So if you multiply that by 12 months, $40,000. Well, if you're a Hollywood star, you can afford it. Probably if you're living here, other than the Clintons, no one's going to be able to. And the pathophysiology of type 2 diabetes is very complicated. And as I take you through that, if we have 8, someone said, well, what about the 11 problems? Yes, I can make 12 or 13, which I'm not going to when we talk about this. But if you have 8, 9, or 10 problems, pathophysiologic-wise, no one drug's going to correct 8 problems. You're going to have to use drugs in combination. So, this is why we fail. This is the treat to fail approach, which happens every day. So, we see the patient, we start the first agents using metformin. You can see the little dashed white line, and you can see it comes down, then it rises, then we add the second drug. 43% of new prescriptions in the US is metformin. Second line drugs still remain sulfonylurea, 33%. You're going to fail, and then we're going to have the third agent. The third agent is a DPP-4 inhibitor. That's 31% of new prescriptions in the US. And the highest, most prescribed drug is insulin. So 3 oral agents, you end up on insulin. That's 45% of new prescriptions. And you can see with time, this progressive rise in the A1C, and we never get the patient's control because we're never sort of treating prospectively. And the other big problem is that we have to understand that this is a very complicated disease. So when I gave the Lilly lecture in 1987, I simply called it the triumvirate. 3 problems that we had to deal with. Insulin resistance in the liver, insulin resistance in the muscle, and beta cell failure. So, you go to sleep at night, your fasting glucose is 80, and you all woke up this morning because you're here. Well, why did that happen? Your brain has an obligate need for glucose. It cannot utilize any other metabolic fuel. So if you're not eating throughout the sleeping hours, how do you keep your glucose in the plasma at 80? Your liver puts glucose into the systemic circulation at a constant rate, and it keeps your fasting glucose at 80. Your brain's happy, you wake up. The diabetic liver is very resistant to insulin. So it overproduces glucose throughout the sleeping hours, and that excess production of glucose by the liver is the main cause of fasting hypoglycemia. So we're clearly going to need drugs that work on the liver to shut down hepatic glucose production. The diabetic wakes up in the morning, they're going to have their breakfast, they're going to have lunch and dinner, and the carbohydrate that's in the meal has to be taken up. What tissue takes that up? It's the muscle. But now the muscle's resistant to insulin. This is postprandial hyperglycemia. And then the beta cell in people with type 2 diabetes is programmed to die. That's the genetic basis. We don't understand which are the genes. We've identified some that are playing a role, but we still have a lot to learn about the genetic basis of type 2 diabetes. So obviously, as your beta cells fail with time, the insulin resistance in liver and muscle become more apparent. So this was 1987, pretty simple understanding. And then when I gave the Venting lecture in 2008, I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So if you think 3 problems were bad, now we've got 8. And I think you told me we have 11. That's even worse, but I think I'll make the point with 8. So in the upper left, beta cell's still there. Lower left, insulin resistance in the liver, still there. Lower right, insulin resistance in the muscle. Now, what's driving the epidemic of diabetes is not that there are a whole bunch of new genetic mutations, okay? Unless you want to call the genetic mutation the hand-to-mouth mutation. People put too much food in their hands too many times, and they bring it to their mouth. It's a terrible mutation. Okay? So the fat cell is your friend in the upper right. So you eat excess calories, and as long as the fat were to stay in the fat cells, they can't hurt you there. But as the fat cells start to expand, they become very resistant to insulin. Now you start to break down the triglycerides, you release FFA into the bloodstream. Probably no one in this room, maybe except when you were a fellow, have measured the plasma FFA. No reason to do it in clinical practice. But the FFA levels in our diabetic patients are very, very high. So why is that important? Elevated FFA promote beta cell failure. Elevated FFA cause insulin resistance in muscle. Elevated FFA cause insulin resistance in liver. So that defect in the fat cell with the release of FFA are exacerbating the 3 major pillars that are critical in terms of the pathophysiology of type 2 diabetes. At 12 o'clock at the top is the gastrointestinal tract. So the gut is a giant endocrine organ. So every time you eat a meal, you release 2 incretin hormones, GLP-1, glucagon-like peptide 1, and GIP, glucose-dependent insulin-trophic polypeptide. If you're drunk, you can say those much better than I just said. Okay? So GLP-1 and GIP, when they come out, account for about 70-75% of all the insulin that's released in response to the meal. So is there a problem with the incretin axis? There is. But it's not because you don't make enough GLP-1 and GIP. It's because your beta cells are resistant to GLP-1 and GIP. And in fact, everybody in this room knows, I give you an injection of, well, the 2 big kids of the block now are Ozempic and, Mounjaro, okay? And we just overcome the resistance at the level of the beta cell, and we augment insulin secretion. The alpha cell at 9 o'clock, it overproduces glucagon, and the elevated glucagon levels drive hepatic glucose production throughout the sleeping hours. So we need drugs that will lock down glucagon. DPP-4 inhibitors will do it, as will the GLP-1 receptor agonist. And 3 o'clock is the kidney. And so you and I, every day we filter about 180 grams of glucose, and all of that glucose is reabsorbed. And if I were to infuse glucose in anybody in this room, as I was raising your glucose up to about 180 milligram per deciliter, no glucose would appear in the urine. But once your blood sugar gets to 180, the kidney starts to dump the glucose in the urine. What's going wrong in the diabetic is that threshold has gone increased quite markedly. So even though the diabetic may have a glucose that's 220 or 240, he's not spilling the glucose in the urine. So the kidney is working against us, okay? And I'll come back to that. And then lastly, the brain plays a critically important role. Rachel and I were talking about this earlier. We are faced with this epidemic of obesity, and I know dietitians are not going to like what I'm going to say, but the fact is it is very difficult to get people to lose weight and to maintain it on a long-term basis. Initially, yes, people, for whatever reason, they get on a diet, they're in a clinical program, they lose weight, but almost every study in the world has shown that within 3-4 years they're going to regain the weight. Well, there's a reason for that, and that is your brain has become resistant to a whole bunch of these interacting molecules. So it's resistant to GLP-1, it's resistant to amylin, it's resistant to PYY. This is a disease, okay? And we think that we can just tell the patient in an hour meeting with the dietitian or with the doctor, you know, you take this diet, you do this, you're on a ketone diet, you eat 6 meals a day, small ones, or whatever the hell you tell the patient that that's going to work. It isn't going to work because there are all these serious hormonal disturbances that are driving the patient to eat. So we need pharmacologic intervention in combination with lifestyle intervention, okay? And if the only thing we did was to get the patient not to gain weight, that would be a major advance, okay? If from the diet standpoint, we could just maintain the weight, and then we could then help the patient with a pharmacologic agent, we would be very, very successful. The best treatment in the world is weight loss. That's not the issue. The issue is, can you get people to lose weight and keep it off on a long-term basis, okay? I could give a several-hour lecture on obesity and how to treat obesity, but that's not my goal today. So, when we think about treatment, you know, if we got 8 problems or 10 or 11, however many you'd like, there's no way that one drug's going to correct 8 problems. We're going to need multiple drugs in combination. And that's a major, major flaw of the American Diabetes Association approach, which is a stepwise treat-to-fail approach. The drugs that we pick should be chosen because they correct one of those 8 or 9 or 10 or 11 pathophysiological disturbances. Another major problem with the American Diabetes Association approach, because there actually is not a single mention in the entire 220 pages about pathophysiology and picking drugs that correct the underlying pathophysiology. And we need to start early, because once you start to lose beta cells, now you're in trouble. So you need to stop the beta cell failure. Otherwise, patients can end up on insulin, and insulin therapy is not easy and very expensive, by the way, for our diabetic patients, okay? So, I'm going to take you back to United Kingdom prospective diabetes study, because this is the landmark study in the type 2 field that showed that good glycemic control really made a difference in terms of preventing complications. So when this study was started, there was an enormous controversy. This was started back in the late 1980s. There was an enormous controversy as to whether glycemic control made a difference in terms of the complications. Half of the diabetes world said they're making a difference. There's probably no one here who was alive, or at least in the diabetes field at that time, maybe the two of us, I'm not sure, who heard Dr. Turner present these data back in 1990. Anybody in this room? Even, a couple of us, okay? So half of the people said, they're making a difference what you do. This is genetic. You're going to go blind, develop kidney disease. The other half of people, myself and others, said, no, it makes a difference. If you lower the glucose, we'll prevent the complications. Now, I think everybody in this room understands that hyperglycemia is intimately related to the microvascular complications, but not when the study was done. So there were about 4,300 people in the study, and Dr. Turner believed that if you took newly diagnosed patients, starting with an A1C of 7, which is the first dot on this curve, and you put them on an oral agent, the A1C would come down and it would stay down. Now, he had only 2 oral agents. He had glibenclamide, that's glyburide, sulfonylurea, and he had metformin. Now, this slide is reproduced. I haven't changed anything. This is the exact data from the study. So you can see over the 15 years of the study, the people who were treated with diet and lifestyle, that's the yellow curve. The A1C just rose progressively. It didn't work very well, even though they tried hard to get people to lose weight and exercise. And he showed that all that rise in A1C was because of beta cell failure. Okay? These people were very insulin resistant from the start, but their insulin resistance didn't change. They were already maximally insulin resistant. What changed was their beta cells couldn't keep up with the insulin resistance. The second group in green started on glyburide. It binds to the sulfonylurea in the beta cell and kicks out insulin. The hyperinsulinemia overcomes the insulin resistance, and you can see in the first year A1C came down. What happened after the first year? Goes up straight. Why? All because of beta cell failure. Okay? What's the third drug up there? Metformin. So metformin works on the liver. It's its only mechanism of action. It shuts down that excess glucose production throughout the sleeping hours. You see in the first hour, nice drop in A1C, then A1C goes up, right? So 15 years in the study is, this got a point, yeah. 5 years into the study here, the A1C has now come back to where he started. So Dr. Turner said, look, my hypothesis is wrong. I cannot put people on a single oral agent, drop the A1C, and keep it down. And he published 5 papers, diabetes care, diabetologia, BMJ, and Lancet. He said, I gotta change the design of the study. So if you're on glyburide, I add metformin. If you're on metformin, I add the glyburide. And then if necessary, I add insulin. So now at 15 years, everybody is on metformin in a sulfonylurea, and 65% of the people are on insulin. Now I'm gonna take you across. And what is the A1C? It's 8.6. Now, is there anybody in this room who wants this treatment? You have to be a goddamn fool to want this. This is the primary treatment in all of our patients in the United States. This is the most common treatment. And I know if I go and look at your charts, there are going to be a lot of people who are being treated like this. Now, there are lots of reasons. I mean, cost is a big issue. You know, some people are just used to these drugs and they just can't change. So, whatever the reason is, this therapy doesn't work, okay? But what he showed, and this is what everybody remembers, is that this separation of the curves of about 1% in A1C decreased kidney nerve complications by 37%. So that's what everybody remembers from UKPDS. But what this study also told us is what drugs were going to work and what drugs were not going to work. But we lost track of this, okay? Now, this is what I call the 15-year revelation. We are the stupidest organization in the world, okay? And we can't learn by our own mistakes, okay? I told Rachel that I came back from Kuwait, and I made the next couple of slides just for this visit to Kuwait. This is the second time these slides, next 3 slides have been shown. So UKPDS 1990, I just showed you those data, okay? So 15 years later, we have the ADOPT study by Dr. Khan. And 15 years later, I'm going to show you the ADOPT study that he did a phenomenal job of reproducing exactly what was shown in the UKPDS. So you would think that we would have learned that metformin, self-hormonal insulin therapy fails. No, but we are stupid. So we had to do this again, and 15 years later, we started the great study. So here's now the adopt study. Okay, this is Dr. Khan's study. So here's glyburide, here's metformin. Oh, these are the same two drugs interestingly used in UK-PDS. Oh, look at this nice drop in A1C in the first year. Oh my God, look what happened after this. Does that look like UK-PDS? 15 years later, are we really stupid?
Yes.
Do we have to keep doing the same thing?
Awesome.
So then now, here's another NIH-sponsored trial. This is the GRADE trial. So, this is Dr. Nathan, the NIH, okay? Do we have to waste more money? Absolutely. We've got to waste another $1 billion, okay? So this study was designed to take people who are metformin failures. So by definition, you already failed on metformin. So now, what is the next best drug to add after metformin? So here's glyburide. That's the white curve. Does this look like UK-PDS? Down and up over the next 4 to 5 years. Okay. Here's sitagliptin. Down, up. Okay. What was surprising to me is liraglutide. I thought the GLP-1 receptor agonist would drop the A1C and keep it down. But this is one of the weaker GLP-1 receptor agonists. And here's glargine, okay? Same thing. Why? Because the docs just didn't titrate the insulin up. So this is another 15 years. So we're now, we're up to, what, 2020 or so? Do we have to wait 15 years to reproduce this study again to convince people that this therapy does not work, okay? It just seems like we keep making the same mistake. Now, I understand in certain places, cost is a big issue. Maybe you can only use metformin self-hormonal reason. But you need to understand that these are not the best drugs. And if there are other options, you should consider using them. So I'm going to come back, and I will do this for every one of the drugs we talk about, to the ominous octet. So a little star shows where metformin and the self-hormonal ureas work. Metformin works on the liver. It is not an insulin sensitizing drug. We showed this many, many years ago when we got the drug approved by the FDA. In order to get it into cells, metformin goes in through the organic cation transporter. And the organic cation transporter doesn't exist in muscle. So metformin can never even get into muscle. So it is, and I'm sure you've all tried, it's an insulin sensitizing drug. Absolutely it's not. Works on the liver, shuts down hepatic glucose production. Now what about self-hormonal ureas? Where do they work? You think Dr. DeFronzo lost his speech, okay, for the first time in his life. You don't see them here, because they don't control anything. They work initially on the pancreas, and then they fail after the first year. That's basically no place, okay? And that's the second-line drug that's prescribed by most people in the United States. Now, here are TZVs. Actually, I use TZVs as first-line therapy in all my patients. There's a very different picture. Whether it's rosiglitazone, pioglitazone, it really doesn't make any difference. The initial drop here is different because the study designs are very, very different. But whatever the initial drop is, A1C stays down. And every single one of the 8 studies, totally unlike what I just showed you in all previous studies. So we all think that TZVs are insulin sensitizing drugs, and they are. But if the A1C comes down and stays down, the only reason that that can happen is that there's a big effect on the beta cell. So over the years, we have had the opportunity to using a technique called the insulin clamp technique, where you infuse insulin, and then with radioisotopes, you can measure the total amount of glucose taken up and metabolized by tissues in the body. To do these insulin clamp studies before and after treatment with pioglitazone or rosiglitazone. And if you just look at the height of the bars, this is the amount of glucose that's metabolized. The units are not important, but they're milligram per kilogram per minute. There's about a 35 to 40% improvement in insulin sensitivity. So these are the only insulin sensitizing drugs that we have. Okay? That's a big deficiency in our armamentarium. Okay? But that's not the major mechanism of action. And the major mechanism of action is on the beta cell. So the gold standard for beta cell function, and unless you were a fellow and trained in, maybe St. Louis with, Sam Klein or with us in San Antonio, you probably never done one of these studies in your life. So we do an OGTT, and then we measure the insulin secretory rate. And we express that in response to the rise in glucose. So I give you a glucose to rate, the glucose goes up, your beta cell sees it, releases insulin, okay? So this is a measure of insulin secretion. But the true measure of beta cell function is your beta cell can read how insulin resistant you are. On a separate day, the patients have to come back and have that insulin clamp study. So we now express this amount of insulin secretion for insulin resistant. This is the gold standard for beta cell function. No one can do better than this, okay? So you're drug naive, I put you on placebo, nothing happens. You're drug naive, I put you on pioglitazone, I triple your beta cell function. Or I put you on rosiglitazone, goes up 2.5. The reason why the TZDs are so good is they're not only great insulin sensitizers, they also affect the beta cell dysfunction. So you're correcting two problems at the same time, okay? So, we come back to the ominous octet. These drugs are good insulin sensitizers in the liver, in the muscle, in the adipocyte, and have a direct effect on the beta cell. If they correct 4 of the problems, they're going to be very, very good drugs. Now, people have all kinds of concerns. I'm going to talk a little bit more about TZDs, and they've fallen out of favor, unfortunately, because they're fantastic drugs. And they're very inexpensive. Now, what about cardiovascular standpoint? So the very first cardiovascular study was done with pioglitazone. It's called the PROACTIVE study. 5,238 patients, big study in Europe. To get into the study, you had to have an MI, stroke, something bad. Half the people go on placebo, the other half go on pioglitazone. So what happened? So this is the Kaplan-Meier plot to the MACE endpoint. And the MACE endpoint stands for major adverse cardiovascular events. And there are 3 of them: cardiovascular death, non-fatal MI, non-fatal stroke. And the hazard ratio is 0.84. If it's less than 1, that's good. So there's a 16% decrease in that combined endpoint. So this is highly statistically significant. So why did this drug not get approved by the FDA? Because this was the very first cardiovascular outcome study, and this was the secondary endpoint. The primary endpoint was the MACE endpoint plus leg revascularization. Leg revascularization doesn't respond to anything. So unfortunately, we had to do this study to learn never to put leg revascularization into the cardiovascular outcome study. And poor Takeda got screwed because the p-value for the primary outcome is 0.08. And because it was not 0.05, they didn't get approved. So what did we learn from this study? First thing is we learned you never let a surgeon run a metabolic study. Second thing is you never let a vascular surgeon named Dr. Darnby run a study. And I cannot tell you how many times I came close to killing this guy because I told him this was going to happen. And if it weren't for that, this would have been the first drug approved in the 90s for cardiovascular protection, okay? But if you were in proactive and you had a stroke, and I put you on pioglitazone, there was a 47% reduction in recurrent stroke. 47%, that's huge. So a good friend of mine, Silvio Nzucci at Yale, and a nephrologist named Dr. Kernan, knew this and went to the NIH and said, we should do a study in stroke prevention. And it was called the IRIS study, okay? The Insulin Resistance Intervention After Stroke, IRIS. Almost 4,000 people. Now, to get into the study, you had to have a stroke or a TIA within the last 6 months. But you could not be a diabetic. That was very, very important. So here, you can see the A1C was 5.8. So remember, the pre-diabetes range is 5.7 to 6.4. So the mean is 5.8. So half of the people were pre-diabetic. They were between 5.8 and 6.4. And the other half of the people were normal glucose tolerant. What I want to show you, it didn't make any difference whether you were in the pre-diabetic range or in the diabetic range, the results. And remember, none of these people got diabetes, okay? So they're going to get treated with pioglitazone, and they're going to be followed up for 5 years. And we're going to see who has a recurrent stroke in MI. So you can see the orange curve falls above the placebo curve. So this is the cumulative probability of disease-free interval, and the hazard ratio is 0.76. That means there's a 24% decrease in recurrent stroke and myocardial infarction. This is better than aspirin. This is better than clopidogrel. This is better than combined therapy. This is better than carotid endarterectomy plus dual antiplatelet therapy. And it costs $5 a month in the state of Texas. And you will pay for a surgeon to put them in the OR, probably cost you $10,000, and then they're going to be on dual platelet therapy, and this drug dwarfs. And the fact is, everybody, primary care docs, have a lot of patients with stroke in their practice. So does endocrinologists. We still don't use this drug. There's a little black cloud hanging over it. I'll take you through the black cloud, and then I'll show you the sunlight behind the black cloud. So, incretins, okay? When you ingest a meal, you release a lot of insulin. If I were to infuse the glucose intravenously to raise the glucose to the same amount as occurred after the oral ingestion, you never make as much insulin as when I give the glucose orally. So you take the glucose meal orally. This is what we call the incretin effect. And you release those two incretin hormones that I told you about, GLP-1 and GIP. And they account for 70% of the insulin that's released during the meal. So these are critically important hormones. So what goes wrong with the people with type 2 diabetes? What goes wrong is your beta cells become very, very resistant to GLP-1 and GIP. Now, we have a lot of incretin hormones. The very first one that came was Byetta. This is, remember, the lizard spit. This one you have to give it twice a day subcutaneously. And I'll come back to this in a second because I directed all of these studies. Then we had liraglutide Victoza once a day. Then we had the once weekly ones, exenatide, the dulaglutide, and then, dulaglutide, trulicity, they thought they were the king, and they get kicked in the butt by Ozempic, and there were a whole bunch of Ozempic things. So Novo thought they were the king of the mountain, and then came tirzepatide, and they got kicked off the mountain, and then, don't worry, Lilly thinks they'll still be in the top of the mountain. They got rituximab that's coming, but Novo is that cardiac which is as good as rituximab. So as good as these drugs are, believe me, someone will come and kick you away. The very worst drug, which is what I would say would be Bydureon, I would characterize this as a fantastic drug. The next one, which we might say is maybe dulaglutide or semaglutide, this is a phenomenal drug, okay? And the next one is semaglutide. This is maybe an out-of-space, out-of-world drug, okay? And then the next one, which is Mounjaro, this is not a space drug, okay? But don't worry, here comes the black hole drugs, all right? The black hole is where no one ever goes, okay? So these drugs, if you are obese, these two bottom one guys here, obese, non-diabetic, body weight loss 25 to 30%, and drops in A1C of about 2 or 2.2 if your A1C is in the middle, okay? So these are really phenomenal drugs. If you're an obese diabetic, you always respond a little bit less, about 25% body weight. Now we're approaching bypass surgery, okay? So the problem is not that we don't have drugs. The problem is $1,200 a month, okay? And there's got to be some place where the system is going to back up, because we can't have everybody on these drugs. And these drugs, although approved for diabetes, there are no drugs approved for obesity anywhere. Whether you're in Canada, there are some drugs approved in the United Kingdom for you have to jump through hoops to get them, and you can only use them for 2 years, and nothing approved in the US. So these are great drugs. They effectively lower the A1C. They have a big effect on preserved beta cell function. They inhibit glucagon. They promote weight loss. As I'll show you in a second, they correct 6 of the pathophysiologic problems that are present in our ominous octet. No hypoglycemia, good safety profile, and cardiovascular benefit. So this is the original study with Bayer. And when we designed the study, it was designed in a way that you can do a meta-analysis of all the patients who treated the same way. So it didn't make any difference if you were drug naive or you were on metformin or on sulfonylurea. You were going to get treated with placebo or with the exenatide twice a day. Placebo did nothing in the first 30 weeks. You can see a nice 1% drop in A1C with the exenatide. And then at 30 weeks, if you're on placebo, I add the exenatide, and you can see a nice drop. If you're on the exenatide, it stays down. And after 3.5 years, the A1 is still down. Okay? If the A1C comes down and stays down, this can only happen for one reason. These drugs must have a very powerful effect on your beta cell. And that's why the liraglutide results in the grade were very surprising. Because liraglutide failed. Exenatide, actually in a long-term study, the once weekly actually dropped the A1C and kept it down for 3 years. So I was shocked to see the liraglutide result. I think that durability is something that's characteristic of this class of drugs, but obviously there are differences because liraglutide didn't do this. So these drugs are great at improving insulin secretion, and they work through a different mechanism in the sulfonylureas. They work through the cyclic AMP system, and without going into great detail, you don't get hypoglycemia because they work through this system. There's a gene called PDX that's critically important for beta cell health. That gene is downregulated in your beta cell if you're diabetic, and it's upregulated by this class of drugs. The early glucose transport steps, glucose gets into the beta cell through GLUT2 or glucokinase, they're downregulated. These drugs upregulate these early transport steps, so glucose gets into the beta cells and stimulate insulin secretion more effectively. And then lastly, if you're a diabetic, your beta cells are programmed to die. These drugs prevent beta cell apoptosis. So for all of these reasons, these GLP-1 receptor drugs are fantastic. So what can you expect? So this is semaglutide and dulaglutide. Change in A1C, semaglutide is a little bit better than dulaglutide, and then if we look at change in weight, sema is a little bit better than dulaglutide. But the fact is, look, would you be happy with a 1.4 drop in A1C? I would be very happy. Would I be happier with 1.8? Yeah. But look, I'll take either of these two. Right? You know, they're both great drugs. So here's the new kid on the block. This is tirzepatide. Change in A1C with 5, 10, 15. If you start around 8 or so, I'm going to drop you by 2.3. So I'm actually getting you down into the NGT range. A little bit better than sema. It's a little bit misleading because this is 1 milligram of sema, maybe you can go up to 2, 2.4. And if we look at body weight, here 11%, and more recent studies up to 15%, a little bit better. But the fact is, they both cause a lot of weight loss. The big issue is cost with these newer drugs. There's nothing to do with efficacy. They're phenomenal drugs, but it's difficult for our patients to find these drugs now because the drugs are not approved for obesity. But quite frankly, most of the drug prescriptions are being written by primary care docs for obesity. So it becomes a pain in the butt because I get the patient started from 2.5 of, say, Mounjaro to 5 to 7.5 to 10 to 12. You get them up to 15, and then they can't find the drug anymore. And then now they go a month without the drug, and then I have to start the titration all over again. So a lot of prescriptions are being written for obesity, for which the drug is really not approved. It's approved for treating diabetes. So there's been a big shortage of not only Mounjaro, but also of semaglutide. Okay, so come back to the ominous octet, and you look at the stars. They work here basically to replace your GLP-1 in a pharmacologic dose. Number two, they have a huge effect on your beta cell. Number three, they inhibit glucagon. Number four, the rise in insulin and decrease in glucagon shuts down hepatic glucose production. Number five, in the brain, they shut off your appetite. And when you lose weight, indirectly you improve insulin sensitivity. Correcting 6 of the problems. Going to be a great drug for our diabetic patients. Okay, cardiovascular studies. So left to right, liraglutide in theaters, semaglutide in sustained 6, Bydureon once weekly, and liraglutide in rewind, hazard ratio 0.87, you can read across. All statistically significant except for Bydureon, where there was a very large drop in SGLT2 inhibitors in the placebo group. And if you reanalyze the Bydureon data by taking out the SGLT2 inhibitor, also very positive. So cardiovascular protection, in addition to weight loss, in addition to dropping your glucose, very nice. Skip this. DPP-4 inhibitors, okay? Third most commonly prescribed drug in the US, okay? So I here showing you saxagliptin, but I can show you sitagliptin, linagliptin, they're all the same. Drop in A1C, I added to drug-naive patients, uroglyceride, metformin, pioglitazone, I'm going to drop you about 7. This is about 1/2, maybe 1/3 what you'll see with the GLP-1 receptor agonists, the new ones. The new ones drop you by 2.2, okay? 0.7, 1/3 is effective, okay? And these drugs are expensive, so I virtually never use them. They're very safe, and they're modestly effective, but in terms of saving your beta cells on a long-term basis and giving you a sustained reduction in A1C, they're not going to do that. Now, cardiovascular protection. So this is saxagliptin in SABRE, alogliptin in Examine, and sitagliptin in T2DM. This is about as close as 2 curves can ever be. So one is the placebo and one is the drug. Okay? You can pick whichever one you want. It ain't gonna make any difference how you interpret this slide. There's no cardiovascular benefit. Now, you can look at that in 1 of 2 ways. It's very safe, but it's not helping your heart, okay, which the GLP-1 receptor agonists argue, and no renal protection. SGLT2 inhibitors. So we have 5 of them, and I actually invented this class of drugs, and my significant other said to me one day, she said, Ralph, you're probably the smartest guy I have ever met in my life. I said, yeah, I know that. And she said, but you are pretty goddamn stupid. And I said, oh, yeah, why? She said, but you didn't patent it. I would be a billionaire if I had patented this. I just published all the papers. So the companies are making $1 billion off of my invention. These drugs are very, very effective, and they have a completely novel mechanism of action. They work on the kidney to lower the threshold at which you spill glucose into the urine. As the blood sugar level comes down, because you're putting the glucose out in the urine, there's this concept of glucotoxicity. High glucose makes you insulin resistant. High glucose inhibits beta cell function. So as the blood glucose comes down, I get rid of the glucotoxicity, and you get a nice drop in the A1C, okay? You lose calories in the urine, so at 6 months, you've lost about 2 to 2.5 kilos. It's good. It's not GLP-1 like, but 2 to 3 kilos weight loss, that's good. You can combine it with any other drug because they're working in a very different mechanism. They're very good. They lower your blood pressure because when you spill glucose in the urine, you spill a little bit of sodium and water with it, and no hypoglycemia. So there are both improvements in your glucose, decreasing microvascular complications. We're correcting some cardiovascular risk factors, so we expect to see cardiovascular benefit. So how do these drugs work? Okay, So these are the original studies published in 2013 showing how they work. So we're going to look at urinary glucose excretion here. As I infuse glucose and I raise you from 100 to 180, no glucose in the urine. But this is the threshold at which glucose appears in the urine, and now we see, as I further raise the glucose, more glucose appears in the urine. So this is you and I, we are normal glucose tolerant, they have an A1C of 5.0. If you have an A1C of 6.5, this is the level at which we make the diagnosis of diabetes. The threshold is increased to 205. If your A1C is 7.5, threshold is 220. These are real data from the paper. If your A1C is 8.5, threshold is 240, and so forth. This is very, very paradoxical, okay? And we as physicians, as the glucose goes up, we want your kidney dump glucose in the urine. But the higher your glucose, the more the signal goes to the kidney. It says, I'm going to hang on to the glucose, working it against us, okay? Very strange, right? And maybe the survival reasons for this, many millions of years ago, when you were chasing those big things, Tyrannosaurus or whatever the hell they call it, you maybe get one every month. Then you were fasting in between, okay? Now, if you were spilling glucose in the urine, and your brain has an optimal need of glucose, you die. So any glucose that appeared in the urine, we were going to take it back. So this was an adaptive mechanism hundreds of millions of years ago. Now it's a maladaptive mechanism, particularly in our diabetic patients, okay? So how do these drugs work? So this is what happens in your eye. Threshold is 180, and you spill the glucose. The threshold is increased in a diabetic. Now I'm going to start you on the SGLT2 inhibitor. Do I lower the threshold back to 180? No. Do I lower it back to your fasting glucose? No. I lower it to 40. Now when you think about that, it means if you have relatively normal kidney function, there is no such thing as a non-responder. Because I've lowered the glucose below every person in this room here. I lowered the glucose threshold below your fasting glucose. You will spill 60 or 80 grams of glucose in the urine, but your fasting glucose won't change. Why? So in the process of doing these studies, we discovered a whole new physiology. As soon as the glucose appears in the urine, the signal goes to the liver, and the liver makes an amount of glucose, which is identical to what's coming out in the urine. That is why you can never get hypoglycemia. So if I took a diabetic and their glucose was 150 fasting, and then I gave them the drug, it would start dropping to 130, 120, 110, 100, boom, the liver turns on, and then I keep your glucose at 100. You never can become hypoglycemic. Of course, if you're on insulin or sulfonylurea, but I mean the drug itself cannot cause hypoglycemia. So we come back to the ominous octet. Good effect on your beta cell, good effect on the muscle, but the indirect, because the primary effect is on the kidney, you dump the glucose out in the urine, blood glucose comes down, reversal of glucotoxicity, okay? Next, what about cardiovascular disease? So this is the Emperor-Gregg outcome study, and this was the first publication. What they did is, of course, take people who had a cardiovascular event. And so what's unique about this study is that 100% of the people have had the cardiovascular event. All the other studies with SGLT2 inhibitors looked at populations that were mixed, where maybe half of the people had a cardiovascular event, the other half of the people had risk factors. And that really explains the difference in mortality. Otherwise, in my opinion, the SGLT2 inhibitors are really all the same. So as we go from left to right, so this is the MACE endpoint, major adverse cardiovascular events. So this is cardiovascular mortality, non-fatal MI, non-fatal stroke. And you can see these curves separate very quickly. Within 3 months, there's a statistically significant difference in the MACE endpoint. But look what happened here in the middle. Death, hazard ratio is 0.62, 38% decrease. And again, look at the separation. Literally within 1 month, the curves are separated. And then hospitalization for heart failure, hazard ratio is 0.65. Okay? So these are really phenomenal drugs. Now, if you don't like your patients, don't give them the drug. You'll kill them, all right? But if you like your patients, maybe you ought to treat them with this drug, you know? We all have a few patients we don't like in our practice. Don't give them the drug, okay? If we all have some favorite patients, then you want to give them a double dose of the drug, okay? And I try to tell cardiologists, these drugs don't cause hypoglycemia. Use it as a heart failure drug, okay? Because the drugs are good for heart failure. Don't worry about the glucose. They can't cause hypoglycemia. The same thing is true for nephrologists. Don't worry about hypoglycemia. It protects your kidneys, all right? So it's good food. Now, how do these drugs work at the level of the heart, okay? So the major effects, benefits, cardiovascular benefits, are hemodynamic, in my opinion. So, these drugs are very good at decreasing the afterload. They decrease your blood pressure. And they're very good at decreasing the preload. So, of course, I block sodium reabsorption in the kidney, so salt and water comes out. You go into a little bit of negative salt and water. It's about a liter of fluid and about 150 milliequivalent of sodium. And so your intravascular volume is depleted. There's a decrease in both preload and a drop the blood pressure afterload. But if I drop your blood pressure, your heart rate goes up. If I give you a diuretic and I decrease your volume, your heart rate goes up. Heart rate never went up in any of these big cardiovascular studies, suggesting an inhibition of sympathetic nervous system activity. And in fact, I'll show you in a second, that's true. In fact, there's a second. So we've just completed these studies using norepinephrine turnover, and the drug, they markedly inhibit norepinephrine turnover. And in addition, this is another unique characteristic of this class of drugs. They decrease arterial stiffness, okay? So the average drop in blood pressure is about 6 or 7 over 1 to 2, measured in the peripheral artery. But what your heart is pumping against is what the pressure is in the aorta. These drugs, and you can show this in 2 weeks, markedly decrease aortic stiffness. So you measure 6, 7 systolic drop. Here it's 10, 12, 14. So this is a huge afterload reduction. And it occurs within 2 weeks. So in my opinion, the major cardiovascular benefit is due to these hemodynamic effects. So what's the other potential mechanism here? These drugs switch you over from burning glucose to burning fat. So if I have you excrete the glucose in urine, and your blood glucose drops, acutely your cells are deprived of an energy source. So what do? They start burning fat, okay? And what's the end product of fat? Ketones. Well, ketones are avidly taken up by the myocardium. They're actually more avidly taken up than this glucose. And when you burn ketones, you generate more ATP with less oxygen consumption. So you're basically unloading the heart from the energy standpoint. And actually, we've provided support for this hypothesis as well. So I think these are the two major mechanisms of actions. These drugs do a number of other things. They improve insulin resistance. I don't have time to go into all of this. They decrease glucose. They promote weight loss. They decrease uric acid. They activate the good angiotensin system, the 1-7 system. They decrease oxidative stress and inflammation. They block the sodium proton exchanger. So there are other mechanisms, and every day there's dozens of papers in the literature looking at all of these things. But I think the two predominant ones, as I said, are the hemodynamic mechanism and then the substrate shift. Now, what about diabetic kidney disease? These drugs also protect your kidneys. It's almost like these drugs are too good to believe. They lower glucose, they protect your heart, they protect your kidney. So the first study is the credence. This is canagliflozin. To get into these studies, in general, you have to have a GFR that's reduced, usually less than 60, or you have to have proteinuria. And then the endpoint is doubling of your serum creatinine, having the GFR ending up on dialysis or transplantation. The real endpoint is very, very similar in all these studies. And you can see with the KEYNOTE study, hazard ratio is about 0.65, 35% reduction in that combined endpoint. And then came DAPA-CKD, same thing, curve separated over about 6 to 8 months. The unique thing about DAPA-CKD, 2/3 of the patients had diabetes, 1/3 had non-diabetic kidney disease. So you could have membranous glomerulopathy, IgA nephropathy, lupus nephritis, and the drug worked as well in diabetic kidney disease as non-kidney disease. So this was a major advance for nephrologists, okay? And empagliflozin, the other kidney study, the same thing, okay? And then more recently, we've had the Fidelio study. This is with feninerone and Indria. This is a non-steroidal mineralocorticoid antagonist. Spironolactone and Paralone will do the same thing, but this drug has less hyperkalemia. It's not a glucose-lowering drug, okay? Unlike the SGLT2 inhibitors, but it does give you renal protection. So here is the renal composite outcome that I told you about, and it's a secondary composite cardiovascular outcome, okay? And you can see these curves separate again here about 12 months. Hazard ratio is 0.82, 0.76. So this class of drugs is both renal protective and cardiovascular protective. So now we've gone from having ACEs and ARBs as the only drug until not too long ago, SGLT2 inhibitors, now feninerone, and most recently, if you read the Wall Street Journal, Novo has announced the FLOW study with semaglutide. This is a big renal protection study, and the Data Safety Monitoring Board stopped the study, not because of safety, which is usually what happens, because the results were so overwhelmingly positive, they felt that it was inappropriate to continue the study. So now of course, we haven't seen the data, and we don't have an FDA approval, but potentially we'll have a fourth drug that we can give to our diabetic patients to help protect their kidneys. Okay, so let's come back now to the ADA. We were chatting earlier with one of the folks in the audience that I'm not a big advocate of the ADA algorithm, okay? And you'll see why in a second. So if I were to show you the ADA algorithm for 2 years ago, it wouldn't look like what's up here. First line therapy would say metformin for every patient in the world, okay? Now the first cardiovascular intervention trial with dapagliflozin was 2012, okay? So that's 11 years ago. There have been, I don't know, dozens of these cardiovascular renal trials, but it took until, you can see here, 2023, that the standard approach changed. So now it says first line therapy, if you have atherosclerotic cardiovascular disease, GLP-1 or SGLT2 inhibitor. Fine. A decade, 12 years after all these trials came out, ADA finally changed the algorithm. I'm all for it, okay? The problem is why it takes so damn long to make the change, okay? Then if you have heart failure, it's SGLT2 inhibitor. And then if you have renal disease, it should be SGLT2 inhibitor. So here's the problem. Only 15 or 20% of our patients got heart disease or kidney disease. Most people we see in practice that you see, they don't come to you because they have an MI. Probably when they have diabetes, and then 10 years later they have their MI. So the majority of the patients that we take care of have neither kidney disease nor heart disease. So what does the ADA algorithm say here? What should we do with SGLT2, GLP-1, glitazone, okay? Well, now you have to go back to what the ADA really says, okay? A1C goal, less than 7.5. This never made any sense to me. We make the diagnosis when your A1C is 6.5. We're the only organization in the world where the treatment goal is higher than the diagnostic goal. The only organization in the world, okay? Then it's metformin. And then, if you look at I'll show you what the ADA algorithm is, what it looks like. You need a magnifying glass to read it. But if you break it down, it simply says you can use any of these drugs, and they're all in the same level. This is totally insane. And what's even more insane is the first one is sulfonylurea. You gotta be kidding me, right? And then a DPP-4 inhibitor and basal insulin can be used, equally recommended after metformin. Totally insane. These drugs are not as good as TZDs or GLP-1 receptor agonists or SGLT2 inhibitors. So now, this is 2020, that was 2022. This is 2023. New algorithm. Okay? So what's the difference? Finally, they got sulfonylureas out of the first column. And now this is sensitive, GLP-1 receptor agonist. Oh my God, insulin would be your second choice. Now, they say they're all equal, but this is the way they line them up as you read from left to right. Metformin, oh, here's our buddy here, SGLT2 inhibitor, as used TZDs. And interestingly, the only one that they de-emphasize is DPP-4 inhibitor. So the new twist in 2023 is realignment and less emphasis on DPP-4 inhibitor. I still don't like this. Now here's the ADA algorithm. Now if you can read that, congratulations. And if you have to go through that algorithm to figure out what I just showed you, that's not very helpful, okay? And then there's an even bigger page where they give you all the drugs and they tell you all the benefits, et cetera, which is fine if you have time to read all of this. But and if you're a primary care physician, you're not going to sit and go through all of this. You need a very simple algorithm. Now, today, when we're treating patients, you need to understand diabetes is a global disease. It means that all organs in the body are affected. It's not just glucose that we're thinking about, okay? So, we need to be thinking about combination therapy, and in addition to lowering the A1C, we would like the drug to have some additional benefit, okay? Cardiovascular protection would be great. It would be great if the drug made you lose weight. It would be great if the drug protected your kidney. And I haven't talked about MASH and NAFL, which is now MASH and NAFL. They keep changing that. Yeah, so MASH seems like a bad word. MASH is death. But, you know, this is an important cause of going on to end-stage liver disease and cirrhosis. So we would like protection. And metformin and sulfonylureas really don't do this, nor does insulin, okay? Now, we also need to be thinking about combination therapy, which is really not emphasized until recently by the ADA, okay? So this is now duration 8. So in duration 8, and this is a big study, you can be treated with dapagliflozin, you can be treated with exenatide, or you could be treated with both together. And we're going to look at the drop in A1C. So it's 1.06 with dapagliflozin, 1.29 with exenatide. And when you put the two together, you can see you get an additive effect. Not surprisingly, they're acting by different mechanisms. So that's A1C. Now, oh, sorry about that. Okay, so what about cardiovascular? Okay, so now I'm going to compare EMA alone versus the two together, and DAPA alone versus the two together. And there's a composite of cardiovascular events, it's MI, stroke, cardiovascular death, etc. And the hazard ratio is 0.76. That means if I put you on the two drugs together, compared to either one alone, I get 24% more benefit. Okay? And if I look at myocardial infarction, okay, if I put you on the two drugs versus either one alone, I get 29% more benefit. And if I look at all-cause mortality, always better to be alive, I think, than dead. 0.68, okay? So if you're picking the right drugs and you're using them together, okay, they're not only giving you benefit in terms of better drop in A1C, also I didn't show you the weight data, this additive effect on weight, but you're getting cardiovascular benefit as well. So why would you do this? Unless cost is an issue, okay? And why doesn't the ADA emphasize this in their approach, okay? So, the ADA until 2023 has never said anything about combination therapy. And so we decided that we would do a study to directly address this issue of the ADA approach, which is the treat to fail approach, versus what we thought was a more appropriate combination therapy. It's called the EAT study. The 3-year data published, I'm actually going to show you the 6-year data. So these are drug-naive patients, new onset diabetics, 318, and we're going to randomly assign them for 3 years. I'll show you 6-year data in a second. To initial combination triple therapy, metformin, prednisone, and exenatide. So exenatide is like, this is an old timer in the GLP-1 field, okay? Prednisone, $5 a day, pretty cheap. People don't use it anymore, it's fantastic drug. And then metformin, because SGLT2 inhibitors weren't readily available when we started this thing. Or I would have done it with an SGLT2. Or we do the ADA approach. I start you on metformin. When you fail, and you're going to fail, we add lipizide. When you fail, then we add glargine. We titrate you up to 60 units. And if now your A1C is above 6.5, you're a failure. So the goal was to keep the people with an A1C less than 6.5. Okay? So we wanted to know what percentage of these people at the end of 3 years or 6 years, as I'm going to show you, have an A1C that's less than 6.5. So the goal of therapy, the endpoint in this study, is not the A1C. Because if your A1C got to 6.6, you're out of the study. So the way the study is designed is you can't, even in the ADA approach, you can't get a very high A1C because you were censored, you're out of the study, you failed. Anyway, here's the A1C data. They start at 8.8, and both actually initially good response. At 6 years, here you can see in our approach, the triple therapy approach, the A1C is 6.1. I'm pretty happy with that. With the ADA approach, it's 6.9. But with the ADA approach, remember, as I told you, your A1C couldn't be allowed to go very high, because once you get above 6.5, you're out of the study. Here's the primary endpoint. All right, so if you got into the triple therapy group, 6 years later, 70% of the people have an A1C that's less than 6.5. If you got the ADA approach, 71% of the people had an A1C above 6.5. In fact, if I use A1C of 7 as the cutoff, 90% of the people have an A1C less than 9. This is absolute total destruction of the ADA algorithm. Okay? Unless you're the most biased, blind person in the world, if you saw these data, you would never go back and use the ADA algorithm. If cost is an issue, yeah, exenatide is pretty cheap. And if you can't afford it, you can call AstraZeneca, get the A, C, and E, you get the drug for free for a year. Okay? Metformin is $5 a month. Prednisone is $5 a month. So this is not an expensive approach to therapy. So, if you don't believe the A1C, okay, then here's the pathophysiology behind the study. No one can do these studies. So, with the triple therapy, this is insulin sensitivity. I basically normalize it. You have normal insulin sensitivity. If you are treated with the ADA approach, you are insulin resistant in the beginning, and there's no improvement in insulin resistance. But what about your beta cell function? I virtually normalize your beta cell function with our approach. What happened to beta cell function with the ADA approach? No change whatsoever. Now, are you totally blind? Can you understand? I just gave you a normal beta cell. I got rid of the insulin resistance. I put your A1C to 6.1. Why would you keep using that ADA approach? All right? So, cardiovascular studies, they have 5,000 people. This is not a cardiovascular outcome study, but we measured carotid intermedial thickness. This is a surrogate measure of cardiovascular disease. Progression with the conventional therapy approach, no progression with the triple therapy approach. P-values 0.1. Okay? Triglycerides dropped by 44 with our approach, didn't change with the ADA approach. His HDL went up by 12 with our approach, dropped with the ADA approach. His blood pressure dropped by 7, virtually no change. Okay? It doesn't make a difference what you want to look at. This is just a wipeout of the ADA approach. Okay? So this is the algorithm you should be using, the DeFronzo algorithm, not the ADA one. There are 4 good drugs. Okay? and I will put metformin at the bottom of the list, okay? And these drugs should be utilized because they're giving you, in addition to glucose lowering benefit, they're giving you cardiorenal benefit. And pioglitazone is the best drug in the world for the NASH syndrome. So you can pick whatever four of the four, you can pick whatever. When I leave today, if you just started using 2 drugs together in combination, I'd be happy. If you use 3, I think I'm dying and unhappy. And I don't care if you use metformin, PO, or GLP-1 or SGLT2 and metformin, but if you now start to think about using combination, that's what I want you to do, okay? And these are 4 good drugs. So I know you can't read this. This is now the first time that in the ADA standards of care, there's a mention of combination therapy. So this is the 2022 standard of care. I'll read it for you because type 2 diabetes is a progressive disease. Maintenance of glycemic targets with monotherapy is often possible for only a few years. That's an understatement, but true. Traditional recommendations have been to use stepwise addition of medications to metformin. However, there are data to support, this shouldn't say support, there are data that indicate you should support initial combination therapy for more rapid attainment of glycemic goals and longer durability. They only quote 2 studies. One is the EAT study, which I just showed you. This is the Verify study by Matthews and Delbrado. So finally, there is a statement about combination therapy, but it's taken a long time to get the statement in there, and in fact, it's still an understatement of the way I think you need to be treating diabetics. So that's the last slide in the slide deck. I know this is a somewhat different approach than you're probably used to hearing, but hopefully you'll be convinced by the data so that you'll at least start to think about combination therapy in your patients and maybe using some of the newer drugs. Although pioglitazone is an old drug, metformin is an old drug, and quite frankly, exenatide is an old drug. I mean, we have Cadillacs that are out there if you can afford them, but you can still do a pretty good job with these drugs that are costing $5-10 a month. So we'll open this to questions. Yes?
So in the proactive study, if I'm not mistaken, there was a 19% reduction in the primary endpoint. CHF was increased, but CHF mortality was not increased.
Correct.
So would it make sense to use, in addition to Actos, to use an SGLT2 with it?
Yeah.
Would you think that would have corrected the problem?
Yeah. So this is a great question, and yes, I would use pioglitazone with SGLT2 inhibitor, but now I'm going to take you back to pioglitazone. I didn't put all the slides in pioglitazone. I put you on pioglitazone. The more the weight gain, the greater the drop in A1C. The more the weight gain, the greater the improvement in insulin sensitivity. The more the weight gain, the greater the improvement in base cell function. The more the weight gain, the greater the drop in blood pressure. The more the weight gain, the greater the drop in triglycerides. The more the weight gain, the greater the rise in HDL cholesterol. Something wrong, right? Because if you overeat and you gain weight, then everything gets worse, okay? If you want, I can explain why this paradox occurs. So, if you come back to the proactive study, and I love to do this talk to cardiologists. If there are 100 cardiologists in the audience, and I ask them, what is the only thing in proactive that predicted that you're not going to die? If someone hadn't heard me talk, the number of people who got the question right would be 0. So what is the only thing in the proactive study, that big cardiovascular study, that predicts you're not going to die? It's weight gain. So you can either be fat and alive or you can be lean and dead. Which one do you want to be? Okay? So I think, well, maybe I'd be a little chubby and alive, okay? Now, I'll come back to the question you just asked, okay? So there's a term that's used in proactive. It's called severe heart failure with edema, okay? And if you're in the pioglitazone group, the hazard ratio is 1.46 for that. That means there's a 46% increase in the incidence of severe heart failure with edema. That sounds really bad, okay? Now, if you have heart failure, 25% of the people are dead in 1 year, and 75% of the people are dead in 3 to 4 years. So if you have heart failure, you would expect a lot of these people to be dying. So if you have severe edema, severe heart failure with edema, what is the hazard ratio for mortality? 0.70. There's a 30% reduction in death. So now, here on one hand, severe heart failure with edema, hazard ratio is 1.46, 46% increase. But the likelihood of you dying is decreased by 30%. You understand it's a paradox. So what's the paradox? The fact is the drug will make you cause fluid retention, right? But fluid retention does not mean heart failure. So why do you retain fluid? This class of drugs, they're powerful vasodilators, and they release nitric oxide. So when I drop your blood pressure and I underperfuse your kidney hangs on to salt and water. In fact, that you retain fluid means that really the drug is working on the vasculature. So then what happened is the people who were treated with the diuretic, they got rid of the fluid, and now you see the benefit of pioglitazone and people live long.
Are you still of the opinion that we should be using 30 milligrams of Actos rather than 45?
Yes, I virtually never go to the 45. And they're always going to be on an SGLT2 inhibitor with the GLP-1 receptor agonist. And when you do that, they lose weight. They never see you weight.
And one other question, as long as we're on Actos. Your study in the New England Journal in terms of people that are first-degree relatives of diabetics,
Yeah.
was like about a 75% reduction in the appearance of diabetes.
Yeah.
And the only way we can compare that is the diabetic prevention program, which was 58% with diet and exercise, which always worked, right?
So,
And metformin, I think 30%.
Yeah.
So are you still an advocate of using pioglitazone for primary prevention,
so
first-degree relatives?
first, I say there's no drug approved for treating prediabetes, okay, just so we understand this. So if you're going to use any drug, it's off-label. But in the ACNOW study, which we were talking about, there was a 75% reduction in the conversion rate of prediabetes to diabetes, which is pretty impressive. And Dr. Zimmerman did a study in Canada where he used low-dose rosiglitazone, 4 milligrams, which is like somewhere between 15 to 30 pioglitazone with metformin, 1,000 milligrams, and he saw a 78% reduction. Wow. So we saw 75% with pioglitazone, 45 milligrams. So actually, what I would recommend if you had a really high-risk patient would be probably 15 of pio and a gram of metformin. The scale study, which I was also part of, in the scale study, the conversion rate of prediabetes to diabetes was 80%. So that's, with the GLP-1 receptor agonist. So they also are very effective. There are choices, and remember, if your A1C is 6.4, you're a pre-diabetic. At 6.5, you're a diabetic. Believe me, there isn't any difference. And if you're 6.1 versus 6.5, the difference just got to do with the severity of the underlying pathophysiology. Eventually, you're going to get from 6.1 to 6.5. So, would you treat these people? If they have all the components of the metabolic syndrome, and the mother had an MI that died at 45, and the father had a stroke and died at age 48, and they were diabetic, of course I'm going to treat the pre-diabetic. If your A1C is 5.7, no family history of cardiovascular disease, maybe I would just follow that person. You have to use, I think, some common sense to sort out who are the high-risk ones that treat me, not treat.
Okay.
Thank you, Dr. DeFronzo.